Hello, Block One wonderful students. This is the chapter on implementing. Again, very, very critically important part of the nursing process. So make sure to review your key terms at the beginning of the chapter, look at the NCLEX questions at the end of the chapter with the rationales, and review this information as often as needed to make sure you have a thorough understanding of it. Here are the learning objectives for this chapter. Please take a moment to review each one of these and apply them to your learning practice. Nurses are focused not only on the patient's treatment plan, but also the patient's response to the plan of care. We look at the whole patient. So the implementation phase of the nursing process is carrying out the interventions that we created in the planning phase of the nursing process. Our goal is to help the patient achieve their desired outcomes, to help promote their health, restore their health, and to help them cope with any type of alteration in their health or their ability or function, right? And this could be temporary or sometimes permanent, right? So part of our job is definitely dealing with helping them cope with that, right? And that's why nursing focuses on the patient holistically, whereas doctors genuinely just want to get them past their current in the hospital setting, at least, get them healthy enough to go home, right? And so forth. So we also need to continue to reassess our patient frequently, collect data, and implement our patient's plan of care. And we're going to update that as frequently as we need to, right? And modify it, the treatment plan. And of course, we're going to document this very thoroughly. The nurse scope and standards of practice describes the who, what, where, when, why, and how of nursing practice. So let's just look through each of those, okay? So we're starting with the who, right? Registered nurses, RNs, or what we call APRNs, or advanced practice registered nurses, comprise the who the who category and have been educated, titled, tested, licensed, and they know, right? RNs and APRNs know they have to keep an active license in order to practice nursing, right? Okay, so next is what? Nursing is the protection, promotion, and optimization of health and prevention of illness and injury, facilitation of healing. It's alleviation of suffering through proper diagnoses and proper treatment to the human response, right? We are advocates for our patients and individuals, right? Families, we're advocates for families and groups and communities and populations, right? That's a big piece of the what. Next is where. Wherever there is a patient, that is the where. And they can be literally anywhere, right? Whenever there's a need for nursing knowledge, nursing compassion, nursing expertise on processes and all that, right? That's the when. Why? The profession exists to achieve the most positive patient outcomes possible. And in keeping, with our nurses' contract to society to say, hey, we are your voice, right? Advocacy, the third threshold concept in nursing, right? So that's the why, right? That's why we do it. That's why all of us have been drawn to nursing, right? We love being someone's advocate and their protector and their voice, right? That's why we're here, most of us. Okay, so the 7 domains are physiologic needs, right? Basic physiologic, complex behavioral, safety, family, health system, and community. Each intervention has a unique number or code, right? And the classification is continually updated, right? So these codes change because it's an ongoing process, with feedback and review and new things popping up, right? And then continuity of care and coordination will enable care coordination by creating the conditions and relationships that supports that seamless interactions, right, with multiple healthcare providers, interdisciplinary teams across multiple healthcare settings and things like that, right? So it makes sense that this helps to improve patient outcomes and patient care. As with other phases of the nursing process, we will use clinical reasoning and critical thinking. Those are the other two of the three threshold concepts, right? So critical thinking, clinical reasoning, and advocacy, right? And then there's a fourth one. It's resiliency. So to be a good nurse, students have to be resilient, right? Because nursing school is going to be the hardest thing you're ever going to do in your life, right? And so you got to be resilient, right? And in a professional, respectful manner, right? And so by going through that, though, what's unique is you learn and you develop the resiliency to succeed, right? And again, you do so in that professional manner, right? So it just comes all together. So anyway, we always want to make sure we are using the most current evidence-based practice interventions, right? So for example, some things are set and don't change much, but other things change more frequently, like wound care. So for example, you can, if you're willing, and a lot of your employers will pay to get you wound certified, national wound certification, right? So that is one thing. When I was nationally wound certified, I didn't keep up with it. I wish I had, but I had to stay ahead of that, right? Because there were new evidence-based practice articles and patient scenarios coming out all the time that had better ways to treat certain types of wounds and things, right? So I was the one that people were coming to for guidance on how to treat a wound. And if I wasn't using the most current evidence-based practice, then the interventions were not going to be as effective as they could be, right? So that's a piece of being a professional nurse, right? Is that you have to, on your own time, you're going to have to do research and stay up on what's latest evidence-based practice. And then again, by assessing, reassessing, revising as necessary, documenting all of this, right? This is what helps bring that safe patient care into place, right? There are different types of nursing interventions that can be carried out. So we have a direct care intervention is when you are working directly with the patient, carrying out a treatment, or maybe you're counseling the patient, right? An indirect care intervention is when you are performing a task for the benefit of the patient, but not working directly with the patient, right? Conducting a patient care conference, researching interventions, or following up on labs or diagnostic results would all be examples of this. Let's see what's next. A community intervention would be something to promote the health of a community. For example, like participating in a blood pressure screening or cholesterol screening, or I volunteered for the COVID clinics when the state provided them out at the state fair. And so I helped with that. So basically your focus of your interventions also vary depending on the type of nursing diagnoses you are working on, right? Interventions for actual problems that exist are aimed at resolving the problem, preventing it from reoccurring, and monitoring the patient's status as we're trying to solve it, right? For the actual nursing diagnoses, you should always have what I call action or doing intervention. So they should be actionable items, right? Because it's a current existing problem. So let's see. Most nursing diagnoses can have at least 4 to 5 interventions to be performed. So when you're doing your care plans, you need to have 4 to 5 interventions for your nursing diagnosis. Okay. The nurse is going to act in partnership with the patient and family, right? Let me stress that, before implementing that plan of care, right? And also we're going to reassess the patient to determine whether the action is still needed, right? If any time goes by before you're able to actually implement, that action, then you need to reassess really to see, is it still needed, right? Because it may have resolved on its own. This happens occasionally, right? It does happen. So don't waste your time, reassess, right? Approach the patient, always approach your patients competently, right? Approach the patient always caringly, right? Modify your nursing interventions according to the following, right? So first, patients, right? You're going to modify the interventions according to the patient's developmental or maybe even psychosocial background, right? Two, you're going to modify it based on the ability and their willingness to participate in the care plan. And three, finally, you're going to modify it based on responses to previous nursing measures and or progress toward that goal or outcome, right? Check to make sure that the nursing interventions selected are consistent with standards of care and within legal and ethical, actually, guides to practice, right? And you always want to question the nursing interventions to make sure that they're the best of all the possible alternatives that currently exist, right? So you're going to be researching that as well, right? So you can see a common theme here, right? We're going to be doing a lot of research and a lot of education too. Then, of course, you're going to want to develop a repertoire of skilled nursing interventions, right? The more options one can choose from, the greater the likelihood of success with your patients, okay? While implementing the plan of care, you must continually reassess your patient's condition to make sure the interventions that are being carried out are necessary, right? Or that they're effective, or to check to see if your patient's condition has changed. Has it gotten better? Has it gotten worse? Or do I need to adjust the interventions, or do I need to add a new one, or has this problem resolved, right? So this is like continually going on all day long with all of your patients, right? Your interventions must be based, again, on the best scientific evidence-based practice. So scientific research, right? It must be based and support the nursing professional standards. It must be safe for your patient, right? These are all factors in it. We're always going to try to promote our patients' return to self-care. And on that note, we're always going to want them to try, right? So when we have a patient who, let's say, for example, you have a patient who has a CVA and, they have a right CVA and they're weak on the left side and they've had a swallow study and they need nectar thick liquids and food and, so you're going to go in there and you are going to help feed the patient, right? Because they're weak on their left side and they happen to be left-handed and they don't use the right hand ever, right? So you're going to go in there and you're going to help them. But does that mean you're going to go in there and feed them, every bite, you doing all the work? No, you're going to, yeah, you probably will start with a couple bites, but then you're going to say, okay, let's have you try, right? And it's okay to, to watch them a little bit and have them try. That's okay. That's not cruel. That's encouraging them, one, to use those muscles to regain that strength back, but two, like you're showing them the right way to do that, right? Again, the goals for their day. Whiteboards are great ways to write what the patient's goals are for the day. And I know we do this across all the hospitals across the nation. So, when you've been enrolled for a while, or if there's call outs, or right now it's just crazy short everywhere, right? I see this getting skipped a lot, right? These little, what some people call niceties, but I actually, that's offensive to me because you shouldn't do the things that bring comfort to your patient and call them niceties if just because it's busy, right? That's a whole different problem, which should be addressed in a whole different. You definitely need to address that. Don't get me wrong, and we're working on it, right? But to your patient, never. And you're not going to cut corners because you don't have time. You're not going to do that. I know you're thinking that's unrealistic because you're going to have to cut corners, but it's not. Trust me when I say it's not going to be on patient care. It's not going to be on patient safety. That's not where you're going to cut the corners, right? You will figure out where to cut them, but it isn't going to be on anything that's going to jeopardize your patient safety, right, and care. So keep that in mind, right? Okay. What else do I want to say here? There's some good examples of whiteboards usage in your textbook, so definitely take a moment and look through those. just to see the different things that are so helpful for your patient, right? Especially patients, for example, I think this is in the book, but you have a patient who's got significant pain, right? And many times when pain can really neurologically impact you, and you may tell them, you don't have any more pain meds until, 2 hours from now. And so they keep asking for it, right? Because they can't remember you told them in 2 hours is when you're able to have pain meds. So what do? You write it on the whiteboard, right? We've all done this. You write it on the whiteboard. Here's when you can have pain meds again. So they can look up the whiteboard and they get used to it after a couple times forgetting that it's on the whiteboard. They actually get used to it, and then they're more independent, right? We're trying to make them as independent as possible, and also trying to free up a little bit of time. So they're not on their call light every 15 minutes for pain meds, or whatever. That's just one example. Okay, you need to be organized and efficient in the implementation phase of the nursing care plan. So you want to make sure your patients are involved in their plan of care, and you want to have make sure they have the physical and psychosocial strength for them to carry out that plan of care. Make sure if visitors are in the room and you need to do an intervention, that you ask the patient directly if they want them to stay in the room or leave their room for a few minutes, right? It's always important to ask the patient whether it's an invasive or not, right? You want to ask them. Let's see. Get caregivers involved in the plan of care, because they're going to be helping carry out the interventions at home, right? So if the patient's getting discharged from the hospital and home health is coming in, and they're going to have caregivers or whatever, they're going to hire private caregivers. Yeah, if the patient is on board with you teaching them, we'll teach them how to do that. We do this in hospice all the time. We teach the patients, caregivers, how to care for different things, right? How to hand out meds, right? Med techs, those kinds of things, right? Definitely want to encourage your patient to speak up, because it's their plan of care, and therefore should be directed by the patient. Seems common sense, but people forget that. So have them speak up. It's important that they voice their concerns about either symptoms they're having or issues that haven't been addressed. Take a moment to review that. Anticipate and properly use any equipment you might need to carry out the intervention. Always use lifts or assisted devices when necessary to prevent injury to you or the patient. Make sure you can create a respectful and clean environment to carry out your interventions. And always assess if you will need assistance from other staff members to successfully carry out whatever intervention you're doing. There's nothing to be ashamed of in asking for help and asking for advice and asking for assistance from nurses, other healthcare team members, right? We all do it. Whatever makes your patient safety measures improves that and their outcomes, you do it. If you don't know something or you're unsure, you have to ask. You cannot afford to be wrong very often in nursing, and you can't be expected to know everything. So in class, we're going to share, Marcella and I are going to share our near misses, and things like that to hopefully encourage you to be as thorough as you possibly can be, because you know you're pretty safe when you come out initially as a nurse, right? Because you're remembering all the checks and all the things you have to do. But as you move from a novice nurse and advance up, then or stages of nursing, and you get, to the area where now you are the person people are coming to for advice. I'm going to warn you, you get complacent with some things, right? And what I'm going to tell you now is try not to do that, because that is when you're going to make a mistake, is when you become complacent and you start editing or, skipping steps, right, to save time. That, I guarantee you, it's going to cause problems. We're going to do a real case study of patient's death, and go over every single step that occurred. It's a really cool case study, but it's just take the time, okay? Trust me. So as a nurse, what are we always asking ourselves? We're asking ourselves stuff like this. What if X, Y, and Z? This is what sets the nurse apart from other supportive nursing personnel, right? because we're always asking and we're always evaluating and we're always looking for the what ifs so that potential problems don't become actual problems. Does that make sense? So in school, we are always going to teach you to say, what if this, and what should I do about it? So the figure on this slide and in your book has some really good possible very dangerous situations and examples on how to plan for these and some possible results. So please take a moment. It's very important to pause, look through these, and in your book. And the goal is to think about the possible errors so that you can catch those errors before they happen, and therefore prevent negative outcomes for your patients, right? If you get to know your patients and you follow the policies and procedures of your organization and the ones that are set out in the scope of practice for the Arizona State Board of Nursing or whatever state you're working at, you ask questions, you're double checking things, you're clarifying things, you're offering help, you're asking for help, you're being physically and mentally present at all times with your patients. You're confirming orders and you're confirming options for additional orders that you may not have, right? All of these things are going to improve your patient's care and their outcomes, right? And we also need to promote our patients' independence by encouraging them to get involved in their care, right? So you want to teach them how to be independent in their care, and you want, because that's our job, right? Being a patient advocate, right? So that we want to make sure we are advocating for them and encouraging them to be an active participant in their care. Be sure that each nursing intervention is supported by a sound scientific rationale as demanded by an evidence-based practice, right? That's how we work in medicine, in nursing. Everything is done based on evidence-based practice. What does that mean? What worked well in the past, what didn't work well in the past, dictates what is scientifically the rationale behind what we do, right? And so you just need to be aware that we are always doing what's most best current evidence-based practice. Be sure that each nursing intervention is consistent with professional standards of care and consistent with protocols, policies, and procedures of your agency. You want to be sure that the nursing actions are safe for this particular patient. You want to make sure it's individualized to that patient's preferences. And you definitely, when you're going through, you want to clarify any questionable orders. Okay, so don't assume just because you've seen them a million times from prior patients, right? Everybody's different. So clarify any orders that are missing details. Variables influencing outcome achievement. Okay, there are certain variables that can influence our patients' outcomes. These include accurately identifying your patient's developmental stage, so as to implement the correct interventions and to identify the psychosocial needs of the patient so as to not implement ineffective interventions or interventions that the patient is not willing to do and participate in. They're not going to do them. So why, right? We talked about that. Their nurse's ability to critically think, their expertise, their knowledge, the time they're available, creativity, their influence over the effectiveness, that all of this influences the effectiveness of your care plan, right? Critical components of that care plan. Your book goes over the intervention strategies nurses can use to improve their critical thinking. So please take note of this, and you definitely want to write down ample notes from the chapter surrounding critical thinking, right? Also, resources at the facilities can enhance or limit your nursing intervention choices. So please keep that in mind as well. And you have to be mindful of the patient's available resources, as there might be limitations there also, right? Like we talked about the Eliquis earlier. There's some people who just cannot afford it, right? Is Eliquis the only blood thinner we have on the market? No, it's not. Is it the one that surgeon or doctor wants? Yeah, but if the patient can't afford it, we either come up with a coupon, which we do have some, right? Or if the coupons are no longer offered by the drug companies, then you come up with a different med that they can afford, right? Because they're not going to buy it if they can't afford it. Failure to practice at these standards can leave the nurse vulnerable for a charge of negligence. Let me repeat that. That is critically important. Failure to practice at these standards can leave the nurse vulnerable for a charge of negligence. So, what I'm going to say to you is this: I sit on the scope of practice committee with the Arizona State Board of Nursing, okay? It's a volunteer position, it's a lot of work, and I love it. I am, those hearings and everything is part of public record. So you can come in and you can witness when a nurse is charged with negligence. And a common theme in these hearings from nurses who've practiced for years and have never had a charge and then all of a sudden have charge, the words coming out of their mouth is this: I didn't know that. So I didn't know that, right? So do you think by saying to the state board, something that was taught to you in nursing school that you didn't know that is going to be a viable reason when you're in your hearing with the state, whether or not to pull your license and never allow you to work as a nurse again in the U.S.? I mean, so so please, learn your stuff now, devote the time to it so that you're a safe, effective nurse, and you won't be called upon, for breaking the law, breaking the patient's rights, right? So using evidence-based practice is how we operate basically in nursing, right? And you can see why, right? Because we have to have the scientific rationales for our interventions. And you will learn these as you go through nursing school and your continuing education. We're going to be doing a lot of it in the lab and in class. And your textbook has some wonderful information in it. To have a bunch of websites where you can find evidence-based interventions for all the different types of illnesses and conditions. So you want to make note of those and look one of those up. And lastly, you need to practice ethically and legal and within legal interventions, right? Because you're accountable to know what is your legal boundaries. So I'm going to tell you right now, the legal pieces of nursing is going to be tested heavily on. So memorize them, commit them to your long-term memory, come up with patient examples of the different types of laws that you can break, and they're going to be continually tested on. So again, memorize it now, and you won't have to worry about it. Not memorize it, commit it to long-term memory now, and then you don't have to worry about rememorizing it later in the future, right? I'm going to tell you right now, nursing school is not a place where you can study like you used to study for all the other classes you took. So, and I'm not talking everybody, but the majority of people, right, would commit the information into your short-term memory long enough for the exam, and then a month later forget it. That's not going to fly in nursing, because everything we do, we retest on in blocks 2, 3, and 4 that we've done in 1. Same thing with 2. 1 and 2 is tested on in 3, and 4 is tested on 1, 2, 3, and 4. So you got to know the information. You're going to use it for the remainder of your life. So you might as well commit it to your permanent memory now. Common reasons for non-compliance from patients, right? So why don't they comply, right? I mean, we went through the plan together, and I asked, for their input and all this, but why did they not comply? Well, here we go. These are the reasons. Lack of family support. It's a big one, right? Or we didn't spend enough time on explaining why. Why is this beneficial to you? So they don't understand the benefits, and therefore they're not vested in it. They're not going to do it, right? Low value attached to the outcomes, right? Like, if this happens, I really don't care. But we care in the medical, right? But we have to make them care. And there's tricks to that, and we'll talk about those in classes. Maybe they have an adverse physical or an adverse emotional effect of treatment, right? Some of the meds we put, for example, hypertension meds, right? Many men will have um, erectile dysfunction with cardiac meds, right? So many of them, though, do you think tell their doctor? No. What do? They just stop taking their meds, right? That's one of the reasons, right? They're not compliant because of the side effects of the medication. They do need to have those conversations with the doctor, though, because guess what? There's other meds we could potentially put the patient on. So it only makes sense to have those conversations. It may be a big one, inability to afford the treatment, again, like Eliquis, right? And then, or they have limited access to the treatments, too. That's a big problem. So an example of that, there's a lot of them, but one might be, at discharge, the patient's adamant about going home, but they really probably should have went to rehab because they're not strong enough, and they're an elderly patient, and you can really lose your muscle mass and your ability to get up and walk on your own really quickly. The elderly patients can, right? And so, but they just blatantly refused and they go home, and then they find themselves on day two calling in to the Honor Health line where I work saying, I need help. I can't get out of bed, right? Guess what? Well, that's a problem because Medicare has very specific guidelines. So usually what ends up happening is we have to bring them back into the hospital, reassess and treat, and then discharge them with a safe plan right after. So and considerations to make when implementing your plan of care are always going to be this. You're going to continue to assess your patient. You're going to continue to gather data with each patient interaction every time you go in the room, right? So many things can change very quickly with our patients, and they do. And you got to stay ahead of that, right? And you got to track those changes, and you got to figure out what's going on so that you can connect with other healthcare team members and get the interventions in place to improve patient outcomes, right? So gathering this data is essential and critical to positive patient outcomes, right? Because it leads to you discovering new problems quicker before they grow into bigger critical problems, right? And of course you have to document all of it, because if you didn't document, it didn't happen. You're going to get sick of, hello, can I talk today? You're going to get tired of hearing Marcella and I say, if you didn't document it, it didn't happen. But it's the honest to God truth. Let me tell you something. I worked at Hospice of the Valley this weekend, right? And I worked 12 hours on Saturday and I worked 6 on Sunday. And I can't tell you one single patient name, or meds or wound care, all of the things that I did. I have a vague sense of what I did, but do you think if I was called in a court of law that I could quantify that? I'm not going to remember these things after a couple weeks, right? I don't even remember right now. I couldn't tell you the documentation of when I gave the pain meds and stuff like that, right? So it's very, very important. If you didn't document it, it didn't happen. In a court of law, whether you did it or not, the judge and jury are going to say, I'm sorry, you're saying you did X, Y, and Z, but the chart doesn't reflect that. And this is the legal record, right? So you got to get it in the legal record. So what do you do? What can you do when your patient does not want to participate in their care? You have to inquire, right? All of the reasons why they may not be compliant, right? So you have to try to get to the bottom line of why they're not compliant, right? And then once you know why, you can alter and change that plan of care so that we are able to achieve those goals, right? Because maybe it could be something like simple, like they don't have, I don't mean simple, but maybe something like they don't have the support system in place to do these wound care changes at home, or again, they don't understand the value and the benefit of the intervention, or maybe there is just too much pain, or they're too fatigued to participate in the plan of care, right? Whatever it is, figure it out, alter the plan so that it is achievable to the patient, right? All right. 5 rights to delegation. Okay. So we can't do it all for our patients. So often nurses have to delegate their care interventions, right? So unlicensed assisted personnel, CNAs, right, certified nurse assistants, or LNAs, licensed nurse assistants, often have intervention and patient activities delegated to them by the registered nurse, right, caring for the patient. And the nurse must follow the 5 rights of delegation when we do that, right? And this includes making sure that the task you are delegating to them can be safely delivered by the level of the person you are delegating it to, right? Under the correct conditions, to the correctly trained person, using good, clear communication on how you want the task to be done very explicitly, and make sure you can provide enough supervision to assure it is being done correctly. If any of these elements are not correct, then you cannot delegate that intervention or activity. These are also listed in your fundamental book. So please take a moment to review these and the details of these in the examples that's in your book as well. This slide reviews the essentials of effective delegation. So by following these guidelines, you can safely delegate some of the care safely to other healthcare team members, right? Can you take a moment and think of a common task that you could safely be that could safely be delegated to a UAP? So sit here for a second, maybe pause the video, think about what, as a nurse, if you were the nurse, what's one thing you could delegate safely to your LNA, CNA, UAP? How about obtaining a set of vital signs on a stable patient? When would this not be safely delegated? How about when your patient's not stable? This would address the right conditions aspect of delegation. That would be a great example, right, of when it's not appropriate to delegate. So, do you see why you have to have all 5 conditions all the time to be a safe delegation task that you can give, right? Remember, only the registered nurse can assess, perform initial teaching, and evaluate a patient. Okay, that's the nursing process. ADPI. Remember, you have to be an RN. So if you're a licensed practical nurse, you can come in and reassess, you can come in and reteach, you can come in and reevaluate, but you are never ever going to be the one to do the initial one or doing them on unstable patients. That's always going to be the RN's job. Any form of a task that involves any of these elements cannot be delegated. Remember, nursing process, RN only. Also, as a student nurse, if you have not been trained or have had the ability to at least practice that skill in front of your clinical instructor, then you will need to notify them and have them come watch you the first time you do it, right? Never ever perform any interventions or skills that are not on your skill list, or 2, that we have not trained you how to do and actually had you practice in the clinical setting, and 3, finally have done in front of your clinical instructor. And I'll be honest with you, some clinical instructors, after you do a skill once, will not want you to do it unless you do it with them again too, right? So let's see, what could that be? Maybe placing a Foley. Maybe the first time you place a Foley, obviously the first time you would do it with me. And then maybe if you get another Foley in your nurse on the floor, maybe you want to see how some of the techniques they use, or how they're communicating with their patient, through that. So there is value to seeing how other professionals do it, but not to alter the required steps per se, because you definitely want to always follow what you learn in nursing school as far as the skill itself. But there are other things that you can see nurses do, whether it's organizing their day or reprioritizing, or maybe the communication that's occurring between the patient and the nurse, right? You can pick up really cool things on that. So whether you're able to do, the second time placing the Foley without your instructor, but with your nurse, if you're allowed to do that, great. But if not, then that's fine too. You just call your instructor and they'll come by and do the Foley with you again, all right, with another patient. Okay, in the clinical setting, you will select a patient to care for the shift. Okay, so you're going to be in clinicals. You're going to have 6 clinical shifts, and you will be assigned to a floor, right? So the goal will be to work on the different types of floors, right? And you will work with the different roles within the organization as well, right? Within the healthcare setting, and every shift you're going to pick a patient to work with, right? And it needs to, all 6 shifts, they need to be 6 different patients. So you're going to work with a patient. And it'll be that morning, right? You'll be assigned to your floor, and then you'll go in and you'll ask your nurse. The best thing to do is just ask your nurse, hey, what would be a great patient for me to practice listening to lung sounds and heart tones and doing a head to toe and having conversations about, health history and comprehensive assessments and stuff like that, right? Because 5 of those 6 weeks, you're going to be required to do a full care plan, right? So you're going to need all this information anyway. So a big chunk of your day is going to be spent with your patient, right? Practicing those assessment skills on them and doing all of that. So this slide goes over a checklist of how to prepare for that. So take a moment, look at that. This is also covered in the chapter in your fundamental book. So you want to pause the video and go to your book and look through it because it's critically important to know, right? It'll help you with exams. It'll help you be a good nurse, but also preparing for clinicals as well. Get a good night's sleep the night before clinicals. You want to eat a good meal in the morning. You want to practice good health habits. Do positive things for yourself, right? All key important things, right? If you don't fuel yourself, right? Your soul, your body, your mind, your spirit, then you will not have any gas in the tank per se to take care of your patients, right? Proper preparation and self-care will make for a much better clinical learning experience. All right, soapbox put away. This is the conclusion of the chapter on implementation.